The purpose of this project is to decrease the medication documentation error rate within the group homes of the developmentally disabled and among staff. By implementing increased training for the new electronic healthcare record with interventions for double checking entries such as pop-up checklists, review pages prior to submission, and like a pending approval portal for review by the House RN. RNs currently oversee homes. I am assigned personally 2 houses. One is a 12-bed home, one is an 8-bed home. All medications are administered by staff who, once they are hired, are med certified. They take a med administration class. They are tested on it. They have to follow and shadow the med administrator at the home that they are going to be trained through for 3 days, I believe. And then they also have to do med passes on their own, which are supervised during training for 3 days. And then once the staff feels comfortable enough to administer medications, the RN will come and med certify them. Once they are med certified, they are able to pass medications to the individuals within the homes where they are currently placed. Everything is done at this point on paper. The state is currently transferring over to an electronic health record. The problem with the paper records at this point is that the error rate is pretty high. Many of the staff members that work in these homes are uneducated. Many of them have never used a computer, have no knowledge of how to operate an electronic system. And we did have them go to a training that kind of gave them a quick brush up of how the system works and what document, like vitals, will go in one section and height and weight in another, and where they have to document on the MAR that a medication was given. But the issue with this is that, like I said, these staff members do not have any experience using computers. So I feel that if they are given extensive training, it would benefit and also lead to decreased error in the home. The electronic healthcare record will decrease and minimize the error rates that occur at this time drastically in itself, but I feel that the staff need more support and training, which will help with the error rates even more. They currently document everything on the paper MAR. The RN will go to the home and does a weekly visit where they, for instance, I would go and open the MAR and look at every single individual's MAR, make sure that every day of the week in the time slot that is supposed to be, the medication was supposed to be received, is initialed. If it's not initialed, they do get a procedural error because they're not following the procedure of having to document a MAR. Anytime a PRN medication is given, they have to write a note in the healthcare data book and under the file for that individual, indicating the reason why the PRN was given and what the outcome was, if it was effective or not. If an individual is taken to a medical appointment, documentation notes have to be placed in the healthcare data as well as the patient file. There's just a lot of redundant charting that can be minimized and lead to decreased error with the healthcare record. And I think it would be beneficial for the staff to have added support and more training, and they would understand the purpose and how helpful the EHR system will be once it is up and running and they are comfortable with using it. Right now, there are a lot of concerns on how they will provide care to the individuals in the home and have to document on an EHR record at the same time. The equipment that is being provided are laptops. The 12-bed home, which are the bigger homes, are provided with 2 laptop computers. They are increasing the use of the internet, the data that is used for the internet, because many of these homes are in secluded areas where sometimes we don't even have cell phone signals. Much of the research that I have pulled and extracted indicates that increased training will lead to decreased error and more positive outcomes. The search process was pretty grueling. I feel that evidence related to an EHR system is pretty minimal at this point. Anything that I found was, much of the information that I found was probably past 5 years old. So I did have to go in and edit some of the papers that I used in the articles for this project. Um, Some of the background questions that I asked myself when we were doing this was, how can we evaluate the performance of our medication administration system? Well, at this point, our administration system is fairly outdated and the performance is poor because we're not really monitoring when staff are giving meds. They are to give it at a 7 a.m. or a 7 p.m. medication. They could document on the MAR and just place an initial in a box indicating that they administered the med at 7, but when a supervisor is not around, or the RN doing her house visit for that week, are they really giving the meds on time? So I feel that this system will also make staff more accountable for administering meds when they are to be given, and this would also help with decreased medication errors and prevent staff from administering medications too close within a time frame. The best way to train staff in documenting on the electronic health record, I recommended an additional class and maybe a computer training that can help staff learn more in relation to the computers and how the system will benefit everyone as an end result. Much of the errors in the research that I found to medication errors occur with disruptions during MedPass time. We currently have a separate office where all the medications are kept held in a locked cabinet, and it's pretty optimal for the minimization of error. The only difference is that most of the time we are short staffed, so there is a person who is administering medications and in charge of med passes for that day, but they are also out on the floor providing direct care to the individuals. So in the event that an individual needs them and they're in the middle of a med pass, that could lead to potential error as well. The EHR system will help with this because I will show and give you in front of your um, a visual of what medication was given. If a med is going to be late, alert systems can pop up and say, hey, you are administering a med past the time that it's due. And you can also have and the individual or the staff member can choose to administer the med a half an hour prior or after the time. And if they need to administer it late, there's an option to administer it late. The EHR documents that the med was given late, but then the staff member can choose a reason as to why that med was given late. The goal of this project is to reduce the medication error rate by half within 3 months of the training and intervention initiation. So when this EHR system goes live, we are currently in the midst of inputting all of the patient data into the EHR system. The nurses are in charge of putting many of the records, say the monthly vitals, the heights, the weights, immunization records are going from paper to electronic charting. Much of this data is being implemented by the RN. So it'll start off fresh, and staff need to be trained on how to add all this data into the EHR as well. The data extraction and research, like I said, was pretty time consuming. It consisted of most of this project. I learned a lot in terms of levels of evidence and how that pertains to finding a valid article and how to find research that would be more valid than others.